Hello, and thank you for listening to my clinical case study presentation. My name is Becca Ray. I am a Michigan State University dietetic intern. I did my clinical rotation for my dietetic internship at Sparrow Hospital, and today's presentation is going to be going over my clinical case study, which was done on a patient who had Crohn's disease. So before we get started, I just wanted to provide the audience with a presentation outline. This is basically the order in which my presentation is going to go. So first, I'm going to talk a little bit about the introduction to the patient, some justification for why I chose the patient. Then we're going to go into the patient profile, which is just going to detail information about the patient. The next section is going to be over health and medical history. Then I'm going to go over disease review. So this will cover a lot of information on Crohn's disease. The next section is just going to be the course of events. So this is going to detail the patient's hospitalization. The next portion is the nutrition care process. The next one is going to be the standards of care. And then lastly, I'm just going to go over a brief summary of what we talked about. To start, I wanted to provide some background information and justification for patient selection. So I do think there are a variety of conditions that are viable and appropriate for ultimate case study selection that could be useful and educational in a lot of instances, but I really wanted to pick a case study that displayed a real need for medical nutrition therapy. I do think that medical nutrition therapy is so important and it's integral to the proper management and health promotion of a variety of conditions. One of them is inflammatory bowel disease, which I will refer to as IBD from this point forward. IBD is an autoimmune disease. It's a chronic inflammatory condition that impacts the gastrointestinal tract. IBD is also a general term for two diagnoses. It can be ulcerative colitis and Crohn's disease. My patient in this case study has Crohn's disease. And Crohn's disease is a condition where medical nutrition therapy can have such a significant impact on the management and clinical manifestations of the disease itself. So really, I chose this patient because not only did she have pre-existing diagnosis of Crohn's disease, she also did have some advanced medical and psychological components that were really complex and intricate, and medical nutrition therapy was really appropriate and helpful in the proper management and hopeful eventual discharge of the patient. I do think that medical nutrition therapy was essential to the patient's successful nutrition care process, and ultimately this case study presented a unique and complex opportunity to really display the importance of medical nutrition therapy in managing IBD. Now I'm going to go over a little bit about the patient. So this portion of the presentation will detail the patient's profile. The patient is known and referred to as MTL. She is a 58-year-old female who resides in Lansing, Michigan. She did present to the emergency department at Sparrow Main Hospital on October 23, 2020, and she had complaints of shortness of breath, fever, and fatigue. The patient is widowed and supports herself. She lives alone in an apartment. However, she does have a sister who is very active in the care and support of the patient. MTL also has a daughter who is also very involved and present in the care of her as well. At baseline, MTL is independent in all activities of daily living, and she is currently employed and works for Peckham Vocational Industries in Lansing, Michigan. Since she has been in the hospital, she has not been working. However, when she is working, she does not tell me that she does any purposeful physical activity. So when she's well, prior to admission, she's not doing anything on purpose. And this is because she tells me she is very active and running around a lot at her job. And so she does not feel that there is really a need for any additional exercise. However, I do think it's important to note that she reports She enjoys walking and very low impact exercise in her leisure time. There are no ethnic or religious factors that are pertinent to this case study that are necessary to report. I do think it is important to note that the patient does have a general associate's degree from Lansing Community College, and she also does have health insurance coverage. There are some relevant conditions that the patient had prior to admission, which were obviously her Crohn's disease, fatty liver disease. She did present with some ascites in the abdomen, hypertension, and GERD. And at admission, initially, MTL was diagnosed with pneumonia, sinus tachycardia, systematic inflammatory response syndrome, and respiratory failure. Next, I'm going to go over some health and medical history of the patient. So this is going to detail some lifestyle and nutrition history. So at baseline, MTL reports no use of alcohol, cigarettes, marijuana, or drugs. In addition, she does tell me that she has a regular sleep schedule, but this was when she's well, when she's at baseline, prior to admission here at the hospital, things of that nature. She also reported that she does have an optimal energy intake when she is well. So when she's not in the hospital, she reports that she has a very normal appetite and that she's eating regularly. She also told me that her usual body weight was around 120 pounds and that she really doesn't see any major fluctuations in her weight status on a normal basis. MTL does have a known history of GI complications, so these include peptic ulcers, constipation, pancreatic cysts, her Crohn's disease. She did recently find that she had herpes simplex virus esophagitis. She does have GERD, as I've mentioned, also fatty liver and ascites of the abdomen. I think it's important to note that due to the esophagitis, the patient does have some difficulty and pain when swallowing. However, there are no other obvious or known handicaps or barriers to MTL's food consumption. Prior to admission, MTL was using some herbal medications and supplements, and this includes things like vitamin B12, lactobacillus, ferrous sulfate, and Miralax. The Miralax uses very regularly, and it's basically just to promote GI regularity and to relieve complaints of the constipation. I do think that MTL does display a positive attitude towards nutrition intervention. However, she's very hesitant. She does have a psychological and mental fear to consume food, and this is largely due to concern for negative side effects such as diarrhea, gas, and distension of the abdomen, along with feeling full just too early. And I think this is all surrounding the fear of experiencing a Crohn's flare-up. So because of this fear and kind of psychological component, not that it's bad, but she also decides to try and really stick to a low fiber diet at home. So she avoids things like nuts and seeds and really any high fiber containing foods. She does tell me that she really enjoys things like tuna fish, stuffed bell peppers, turkey meatballs, turkey burgers, some fruit, and also yogurt. On a typical day, it's normal for MTL to try to consume 3 small meals a day, and she tells me she usually consumes most, if not all, of her meals. But she does report occasional snacking, which sometimes inhibits her ability to eat and finish 3 full meals a day. It's interesting to tell you that she does have an extreme dislike for any oral nutritional supplements, and so she does not take them at home whatsoever. And this will be important a little bit later on, and we'll talk about that later. Lastly, there really are no significant genetic or family risk factors to report. Her mother did have a stroke, but her father has no significant medical history. And MTL also has no really significant history of any medical surgical procedures that would be impactful on her nutritional status. Next, we're going to go over the patient's primary diagnosis and go over some disease review, and this will be detailing Crohn's disease. So we'll be talking about the etiology, the pathophysiology, the clinical manifestations, treatment, medical nutrition therapy, and the prognosis and prevention. So starting with the etiology, interestingly enough, there isn't an exact etiology for IBD. Currently, it is unknown. I've researched heavily on this topic, and they all are saying the same thing. Basically, the current hypothesis is that IBD comes from a predicted combination of environmental and clinical factors that ultimately lead to an inappropriate immune response in predisposed individuals. Some of the environmental factors that can lead to IBD include things like smoking, infectious agents, intestinal flora, diet, and physiological changes that occur in the small intestine, which may trigger an abnormal inflammatory response. However, this is all largely unknown. There is no exact mechanism or explanation for why individuals get IBD. The clinical side of it, there are some strong genetic associations that have been seen. I've done some research, and what I've found is that there's a positive family history in about 5% to 15% of patients who are diagnosed with IBD. There are numerous genes that are associated with IBD susceptibility. However, I think it's interesting here in this case because MTL doesn't have any significant known genetic history that I saw when I was going over her case and her history and things of that nature. So really here, the exact etiology is kind of confounding. So I do think that that's interesting in the grand scheme of this case study. Moving on to the pathophysiology of IBD. Much like the etiology of IBD, the pathophysiology also remains largely a theory. However, it is thought through lots of research, they've kind of come to a general consensus here that individuals who present with some form of IBD are typically those who are genetically susceptible and who are also exposed to triggers. And these triggers are highly individualized, so it's very hard for us to predict. But ultimately, when they're exposed to these triggers, they tend to experience an abnormal immune response. And the abnormal immune response that is seen results in the release of cytokines, and cytokines cause the abnormal inflammatory reaction that ends up destroying intestinal mucosa. So a little bit about cytokines is cytokines are small, they're secreted proteins, and they are released by cells that have a specific effect on the interaction and communication between different cells. So I think it's important to note here that there are both anti-inflammatory and pro-inflammatory cytokines that do have a significant impact on the GI tract. And ultimately, usually when you have an overabundance of these pro-inflammatory cytokines, that leads to significant pain and inflammation. In the incidence of Crohn's disease, these cytokines are really the major player. They're the major group of regulatory molecules that are produced by the immune system. So really it's important here that the existence of both anti-inflammatory and pro-inflammatory cytokines throughout the GI tract are crucial for just a healthy intestinal barrier function and ultimately homeostasis. When there are those changes in this very delicate balance between anti-inflammatory and pro-inflammatory cytokines, this can lead to a variety of issues. This can include cell death, cellular infiltration, and the loss of integrity and function of the gut. When you have IBD, it's normal to see episodes of remission and also episodes of flare-ups. So usually, Crohn's disease impacts any portion of the GI tract from mouth to anus. And 75%, according to some research that I found, says that patients who experience Crohn's disease have some sort of small intestine involvement. Ultimately, Crohn's disease can damage all layers of the GI mucosa, and so the inflammatory response seen in Crohn's disease can be categorized by this development of fistulas that, when they heal, are replaced by fibrotic tissue, and the fibrosis can result in recurrent strictures and bowel obstructions, and ultimately that is the thought or predicted pathophysiology behind Crohn's disease. When a patient presents with a Crohn's flare-up, they are very likely to present with some of these clinical manifestations that can include incidences of abdominal pain, diarrhea, and the frequent need to defecate. Typically, blood in the stool is not observed, so it's not likely, but it can happen. And also cramping is very common in a Crohn's flare-up. As I mentioned in the slide previous, usually Crohn's disease has some sort of small intestine involvement. And so because of this, patients who have Crohn's are more likely to be at some sort of nutritional risk. This can be things like weight loss, muscle wasting, and malnutrition. So when you're seeing a patient who does have Crohn's disease and is experiencing a flare-up, it is really important to address these three nutritional risks. These are just the most common ones. And likely this is due to largely the increased requirements that are needed and also the decreased oral intake that is seen when patients are experiencing these negative symptoms. Interestingly, there is some research, although it is not a lot of it, there is some. They have found that there are serological markers that include antibody testing that can distinguish IBD from other GI diseases. So this antibody is the ASCA antibody, and it may be specific to Crohn's disease. However, unfortunately, and this is why it just needs more research and testing, these antibodies can also be present with just other GI diseases, and so it's not really recommended to solely identify and diagnose IBD with these markers alone. But I think aside from GI symptoms, it is also important to know that individuals can also experience extra intestinal symptoms. And so this can be things like osteopenia, osteoporosis, dermatitis, ocular symptoms, and just other hepatobiliary complications as well. While there is no cure for IBD, there are treatments available to individuals who are experiencing a Crohn's flare-up, and these typically include things like anti-inflammatory medications, antibiotics, immunosuppressive medications, immunomodulators, and biologic therapies as well. There are also surgical interventions that can be done, but usually that's the last option, and that's only if the medications do not work. So immunomodulators are ultimately used to inhibit the inflammatory cell proliferation by interrupting the cellular RNA and by inhibiting the overall immune response. There are various medications available that do this and that are typically used for Crohn's disease, however, not always. Corticosteroids are also often used during an acute flare-up, but they're really usually only used in severe cases because there is a concern for patients to become steroid dependent. And so typically they're only used kind of as a last resort. Antibiotics can be used, but they are also usually only used for acute infections as well. And there are also biologic therapy medications that are available. And these biologic therapy medications are used to interrupt the tumor necrosis factor alpha and the cytokine inflammatory response as well. So there are some successes seen in these medications, and ultimately with proper medication use and lifestyle change, typically you can see a nice period of remission in individuals who are using them appropriately. I know I mentioned surgical intervention that can be used for Crohn's disease, but as I said, it's usually a last resort, and this is an ileostomy. Typically, they try to treat with medications first, and then if those are unsuccessful, they will move on to the ileostomy. And basically, an ileostomy is a surgical resection of the colon and the rectum, and it creates a new path for the feces to be excreted from the body. A stoma, which is a surgically created artificial opening in the abdomen, is created during an ileostomy, and that becomes the opening from which the waste products are excreted. And you will see that patients who have an ileostomy will use a pouch where the feces and other waste products are collected. Medical nutrition therapy is going to be a really important component of the intervention used for individuals who have Crohn's disease and are experiencing a Crohn's disease flare-up. As I've said before, they are really likely to experience weight loss, muscle wasting, and malnutrition, along with various nutritional deficiencies, both in calories, protein, fluids, electrolytes, and a lot of vitamin and minerals. So it's important to really assess these types of things. So ultimately, the kind of first line of defense that you're going to see is the need for nutrition support. Nutrition support is routinely required during periods of an acute flare-up. And because IBD typically impacts the digestion and absorption, you may need increased calories, protein, and also micronutrients. It's also important to know that there are medications such as corticosteroids that are also likely to impact your nutritional status, and this is by increasing nutrient requirements and also causing nutrient loss. So as I said, nutrition support is usually going to be the first thing you're going to assess the need for, and this can be if you're seeing a patient who has severe weight loss, muscle wasting, and also malnutrition. Ultimately, we want to ensure that they're getting adequate nutrition in their time that they're at the hospital. And so either parenteral or enteral nutrition may be initiated. It's thought that either one of these can be used to promote bowel rest. However, there is no exact known mechanism for why enteral nutrition is used. It's preferred over parenteral nutrition, and it is thought to ultimately be due to improved intestinal permeability when you use enteral nutrition initiation. So as I said before, malnutrition is also common, and it can present in a patient who is either had a prior Crohn's flare-up or is at present experiencing a Crohn's flare-up. And so you can see things like protein calorie malnutrition along with various nutrient deficiencies such as in iron, magnesium, zinc, calcium, vitamin D, vitamin B12, and folate, as well as other fat-soluble vitamins. Ultimately, these deficiencies can lead to further complications, and this can include things like anemia, osteoporosis, poor wound healing, and a compromised immune system. So therefore, really, nutrition therapy and nutrition support is really important. If you're going to initiate it, it's important to initiate it quickly to get the patient what they need as far as adequate nutrition. And so ultimately, what you'll also need to consider is what type of stage the patient is in their Crohn's disease. So are they presenting with an acute infection, or are they presenting with a period of remission? And obviously, if they're in remission, they're not likely going to be having any symptoms. So if they're in the acute stage, which means they're experiencing a flare-up, their energy needs are likely going to be increased, and their protein needs are also going to be increased. And as I've said, this is kind of likely due to just some of the symptoms that are presented in Crohn's disease, so things like diarrhea and abdominal pain that increase gut motility and decrease the digestion and absorption. These symptoms, like I said, are also likely to cause the patient to have a reduced oral intake. They might be following like a really restricted diet to help minimize their symptoms. And so again, that might be a reason as to why you might see an increase in energy recommendations. As I've said, there are also medications and surgical procedures that are used in the treatment of IBD that can lead to increased energy requirements for things like proper wound healing. So if a patient were to have gotten an ileostomy, we want to ensure that they heal properly from that procedure, so their energy and protein requirements are going to increase. So ultimately, the exact intervention that you're going to use is really going to be dependent on the extent of intestinal involvement, if they've had surgery, how much diarrhea they're having, if there's any bleeding, things of that nature. A lot of literature and research supports the use of enteral nutrition therapy to treat an active Crohn's flare-up when bowel rest is needed, or if they need to maintain nutritional status. Parenteral nutrition may be used if there is some sort of reason for or like a compromised GI tract. It may be required, but it's not the first chosen nutrition support method. Ultimately, the type of enteral formula that is going to be used is so entirely dependent on the patient and their nutritional needs. So that's going to be another thing that is going to have to be like highly individualized and very patient-centered. You also need to look at the amount of weight loss, and if there's the presence of infection, their energy requirements and protein requirements are just solely going to be based on things of that nature. So if they have any lean body mass wasting or biochemical parameters that need to be addressed. Aspen recommendations say that 1 to 1.5 grams of protein per kilogram of body weight is appropriate for adults who are in a Crohn's flare-up. And they also suggest 25 to 30 or more, again, it's very highly individualized, calories per kilogram of body weight for the patient experiencing a Crohn's flare-up. So if oral intake is possible, that is going to be recommended, of course. If we can use the gut and eat, we want to. So if you are going to eat orally, it is important at first to initiate a low residue lactose-free diet and have the patient eat small frequent meals, but only as tolerated. As diet can slowly advance, if we're not seeing any negative symptoms, it is okay and normal to start slowly incorporating small amounts of fiber and also dairy into the diet if, again, well tolerated. Really, fiber is only restricted if super necessary during a flare or a stricture. So it doesn't have to be. You can always try to slowly introduce it. In fact, fiber may be good in some instances. And so that's just, again, going to be something that's highly individualized, and you'll need to work with the patient in order to figure out what works best. Gas-producing foods, spicy foods, fried foods, caffeinated beverages are all things that may be beneficial to reduce in someone's diet. It's, again, just something that is going to be important to the patient. And so, as I've said, it's all very highly individualized, and you're going to have to adjust just the basic needs and work with the patient to find what works best. As I mentioned, micronutrient deficiencies will really need to be addressed as well. Individuals who have IBD are just more likely to experience a intake deficiency due to, as I said, just negative symptoms. Usually when someone has a normal functioning small intestine, the ileum does have specific receptor sites that allow for vitamin B12 to be absorbed. However, when you present with Crohn's disease, and if it affects the ileum, then vitamin B12 deficiency is very likely. So that's also important to assess and look for. So that kind of went over the acute stage. And then lastly, I'm just going to talk about some recommendations for periods of remission. And so really what you're going to want to do if you're in remission is just maximize the individual's energy intake and their protein intake, and also just facilitate rehabilitation of the gut. Weight gain should be, if necessary, it should be normal, it should be healthy. A normal physical activity will help rebuild protein stores and muscle mass, so that's really important to the individual in remission. Also, depending on the individual, there are dietary modifications that may need to be made and adjusted to normalize and reduce any negative symptoms that they're experiencing. So foods that are high in like antioxidants and omega-3 fatty acids are associated with protection against inflammation. And so things such as fruits, vegetables, nuts, oils, and fish can all be really helpful therapeutic diet modifications to be made in the individual's diet. There's also a lot of research that looks at including pre and probiotics into someone's diet because these are known to help enhance normal flora in the GI tract. And so this can lead to just decreased negative symptoms of IBD. And it also can help with the positive change in anti-inflammatory cytokines in the GI tract. Some things maybe to avoid are foods high in oxalate. They may increase the risk for kidney stones, which is usually common with individuals who have IBD. And then there are certain foods such as cocoa, tea, wheat germ, strawberries, spinach, beets, baked beans, peanut butter, tofu, and vitamin C supplements that may want to be avoided because they can cause negative side effects. The prognosis of someone who is living with Crohn's disease is very positive. Most individuals can live and enjoy a happy, healthy lifestyle. As I've mentioned before, there is no cure for Crohn's disease at this present time. But as we've went over, there are various treatments and just lifestyle changes that can easily be incorporated and can ultimately greatly reduce the incidence of Crohn's flare-ups, and then you will be in more periods of remission, and so this will prevent any further complications from occurring. As we know, the etiology and pathophysiology of Crohn's disease is unclear. It's just a hypothesis at this point. So there is no way to actually prevent Crohn's disease from occurring. But as I've said, with proper diet modification and lifestyle change, you can maintain a well-balanced lifestyle. And again, this will reduce episodes of flare-ups. It's also important to, if you are a smoker, to stop smoking. As I mentioned, smoking is one of those environmental factors that can cause or increase incidences of Crohn's flare-ups. And so if you are a patient living with Crohn's disease and you're smoking, it's very highly encouraged to quit completely. And there are also some preventive measures that can be taken, such as having regular colonoscopies and cancer screenings for individuals who have had Crohn's disease for a greater period of time. The suggested amount of time is if you've had Crohn's disease for about 8 years to begin having regular colonoscopies and cancer screenings about 1 to 2 times a year. MTL does have a very extensive hospitalization occurrence. All the information prior to when I started seeing the patient was collected from the EMR system that we have, Epic. And basically, because her course of events is so extensive, I'm going to try to briefly go over some significant things that have happened. I have here listed just some basic significant dates. So she did present to Sparrow ED on October 23rd, 2020. I think I mentioned she had shortness of breath, fever, and fatigue, and her preliminary diagnosis was pneumonia. She also had the ascites of the abdomen, the fatty liver, and after an abdominal x-ray, she was noted to have wall thickening of the luminal narrowing distal terminal ileum, which was consistent and significant for a Crohn's flare-up. So after the initial assessment was done when she was in Sparrow Main Hospital, the diet was adjusted to low fiber instead of a house diet, and the patient was also prescribed an Ensure Compact to increase her calorie and protein intake. And then, unfortunately, MTL consistently saw significant abdominal distension and a lot of discomfort. And so parenteral nutrition recommendations were desired ultimately by the physicians. At the time, she did not have central access, and so PPN, or peripheral parenteral nutrition, was started, and she was started on the lowest standard formula offered at Sparrow, in part to monitor for refeeding syndrome and also tolerance. And so initially, this only provided 840 calories and 42.5 grams of protein, or amino acids, and she had 3 days of this PPN, and then the physician wanted to try trickle tube feeds. However, MTL was too obtunded, and so the trickle tube feeds, they did start, but they did not move forward onto a larger volume. And so initially we just started MTL on Nutrin 1.5 at 10 milliliters an hour. While she was receiving the trickle tube feed, the PPN was weaned, and from this point forward, I'm going to try to, as quickly as I can, go through some more important dates. MTL stayed in Sparrow Main Hospital for a significant amount of time until November 24th. She was transferred to LTAC, and that's where she stayed for a very long time, just over a month about. And ultimately, she ended up going back to the ICU in Sparrow Main Hospital on December 30th. And then as of yesterday, I checked, and she was back to LTAC, so that was January 15th. She returned back to LTAC, and she is still there. So at the conclusion of my case study, unfortunately, MTL is still hospitalized at this point. However, when I kind of concluded my follow-up visits with her, we were at a very positive point, and I'll go into detail about that later. But as of right now, she is, I hate to say it, but almost back to where we started. So hopefully we can, or whomever begins working with her again, can start to see positive changes in her intake once again. I'm confident that since we saw it before, we'll be able to see it again. But her history involves a very significant use of PPN, then TPN, and then ultimately enteral feedings, tube feedings were initiated. We were able to eventually see that she tolerated the hydrolyzed formula, the Peptamen 1.5, the best, and the bulk of the time that I was counseling with the patient, this was the formula that she was on. And ultimately, we started doing nocturnal feedings to promote hunger, and also see if we could get her to improve her oral intake. And so we slowly tried to adjust the tube feed to encourage more oral intake, and eventually this did prove to help. We did have to initiate several weeks of calorie counts just because we needed to get an appropriate estimation of how many calories she was consuming by mouth, because we didn't want to discontinue the tube feed if she wasn't going to meet her needs orally. And so it took several counseling sessions and meetings with her to eventually get the tube feed off. I'm happy to say that we had gotten it off, and she ended up proving to meet her estimated needs orally. However, when she ended up back in the ICU December 30th, she had a mucus plug, went back into respiratory failure, and unfortunately she's back on the tube feeds. She is back on the hydrolyzed formula, and as of the other day when I checked, she is back on the nocturnal feeds. So hopefully we are making progress in that way. This slide details the nutrition care process, and so the first section is assessment, which we will talk about the anthropometrics, the biochemical medical tests and procedures, any medications the patient was on, the clinical and medical conditions and intake, as well as the estimated energy requirement calculations. Then we'll go over the diagnoses that we had for MTL when I was with her and working with her. And next we'll talk about the intervention. So ultimately what we did, I briefly touched on it a slide ago, but I'll try to go into a little bit more detail. And then lastly, the monitoring and evaluation portion, which we will talk about just ultimately the impact of the medical nutrition therapy and any changes in the PES statements. So first off, the anthropometrics in respect to her height, it was 61 inches or 5'1", and her weight at admission was 137 pounds. So her calculated body mass index was 25.9, and her ideal body weight when calculated was 105 pounds. So she was 130% of her ideal body weight. As I mentioned, her usual body weight was 120 pounds. And so she was 114% of her usual body weight. She did have edema present, and so this is likely the reason for the fluctuations in weight that we saw throughout her hospitalization when I was working with her. She did have quite a range, so we went from 106 pounds to 146 pounds. Her heaviest was when she was in the NICU, and we saw that she was severely fluid overloaded, and so that's the 146 pound we saw there. When she transferred to LTAC, the admit weight for her LTAC admission was 106 pounds. So this was after being diuresed, and so we are likely to assume that her estimated dry weight was thought to be 120 pounds. So ultimately we can see that she is not at her usual body weight, but however, she did have an existing diagnosis of malnutrition, and we'll go over that later, but we did our best to estimate her dry weight calculation, and so her dry weight is thought to be that 106 pounds that we see when she was admitted to LTAC. So I only did 2 times where I looked at her labs. There's just too extensive of a admission here to go over every single one. And so what I decided to do was just look at her labs on her initial admission to Sparrow Main Hospital. So that was on October 28th. And then I also looked at her labs when she was admitted to LTAC, which was on November 24th. So this table just kind of breaks it down. We see that the relevant lab values that were elevated or abnormal, I should say, were the sodium, which was, hers was 133, so just a little low, likely attributable to the fluid overload and the edema that we saw. Her BUN was a little high, it was 25. This could be just to poor kidney function. I'm guessing she didn't have any, kidney issues, so this could just be likely due to, the inflammation seen, and it's causing it to be slightly elevated. Her liver function tests were also slightly elevated. She did have fatty liver disease, and so we know that the ALT and AST biochemical lab values are going to be elevated, in instances of fatty liver disease, and so she does have that liver damage, and so it's not surprising that these lab values were slightly elevated. Her ferritin was very, very elevated. It was at 2,799, and I've done some research on this, and ultimately what I found is that your ferritin level in the blood is likely to increase very rapidly and quickly when you are experiencing a state of inflammation. And so we know that she was having a Crohn's flare-up, as we saw from the abdominal x-ray, and so obviously she is having severe inflammation of the GI tract, and so that can be why her ferritin was so elevated. And also her blood glucose was sort of high. I wouldn't say that it was anything to be concerned about. We had a point of care glucose measures, and that ranged anywhere from 79 to 137. And so I think her 137 was likely a result just from the stress and inflammation that her body was going through. I wouldn't really put too much emphasis on this because it's not a primary concern. Of course, we kept looking and watching it, and it did not remain an issue. So when she got to LTAC, there was just a few lab values that were slightly out of the ordinary. Her potassium was 3.5 at this time, and so it's not necessarily low, but it's on the low end of the normal value, and so this was likely to all of the diuretics she was receiving because of her edema. Her alkaline phosphatase was very, very elevated, and I've done some research on this, and the alkaline phosphatase is seen to be very commonly elevated in individuals who have Crohn's disease, and that's just a direct result from the inflammation of the GI tract. And so, again, this is explainable just by the inflammation being seen from her Crohn's flare-up. The next lab value that was slightly elevated was the lipase. We usually see high levels of lipase in individuals who are having pancreatitis or some other type of pancreatic disease. Again, I did do some research on this, and I did find that it is very common for individuals who have Crohn's disease to be at a much higher risk for developing acute pancreatitis, just because of the overall inflammation that's happening. And in the event of a flare-up, you're typically taking a lot of medications, and things like corticosteroids, which MTL was on, can also increase your lipase. And so I think that the medication use here is likely why we were seeing a rise in the lipase. And then lastly, her triglycerides were elevated quite significantly, and this can be really a wide range of things. It can be the PPN use, it can be the diet that she may have been on, who it's really hard to exactly say why her triglycerides were elevated, but my ultimate guess is possibly just a poor diet, and also just the amount of nutrition that she was receiving with the various nutrition support methods that we were supplying her with. Moving on to some of the medications that MTL was on. Again, her hospitalization was just too extensive. Her medications were changing quite often. So I chose to analyze and present on just some of the more recurrent ones that she was continuously on throughout the bulk of her time that I was going over her case study. And these tables just briefly show just some of the medications that she was on. So I do think probably the most important one to cover is the methylprednisolone, and this is a corticosteroid. It's an anti-inflammatory or immunosuppressant medication. Some side effects of this can be increased appetite, weight gain, a negative nitrogen balance, and calcium wasting. There is also a drug-nutrient interaction to be aware of, and this is that you should not be having any citrus, mainly grapefruit, and also no caffeine when taking this medication. A medication that I don't have listed because she wasn't on it at the hospital, but it is a home med, was the biotherapeutic agent, which was the lactobacillus, and that is an antidiarrheal. And as I mentioned in the treatment section of this presentation, they're very common remedies for individuals who have Crohn's disease. And so if you're going to take it, it should be chewed thoroughly, swallowed. You should be having it with some sort of liquid, whether that's milk, juice, or water. And it may cause things like burping and vomiting, and oddly enough, diarrhea, even though it's an antidiarrheal, and increased gas production. There are no nutritional implications or interactions that need to be concerned with the use of this biotherapeutic agent. I did want to just mention it briefly. Some of the other medications that she was persistently on was Zofran, which is the antiemetic. Some side effects are abdominal pain, constipation, and diarrhea. There are no drug-nutrient interactions to be concerned about there. The Abizome was an antifungal. This can cause anorexia or weight loss, and you do need to make sure that you have adequate fluid intake when you're taking this medication. The Lasix, which is the diuretic that she was on to help with her edema, it may cause anorexia. It can also increase your thirst, and hyponatremia is common with this medication use. I already went over the corticosteroid. MTL was also on Protonix, which is just the anti-GERD medication. She, as I mentioned, did have a history of GERD as well. Some side effects can be diarrhea, nausea, abdominal pain, and Protonix can decrease your iron absorption and your B12 absorption. So again, it's going to be important to monitor your micronutrient levels to make sure that you don't need to replenish them. There were times, as I said, where we saw that MTL's potassium was a little low, so she was receiving potassium repletion through medication as well. She was on a significant amount of bowel meds. These are all forms of laxatives. Diarrhea is a common side effect, and you can also see that there may be an electrolyte imbalance when taking too many bowel meds, so that's also important to look at. She was also on Carafate, which is a anti-ulcer and gastric mucosa protectant. This can cause constipation and cramps, and you're supposed to take it with calcium or a magnesium supplement in order to help with absorption. Megace was the appetite stimulant that we ended up suggesting for MTL to increase your appetite. So, of course, some side effects include increased appetite, weight gain, nausea, edema, things of that nature. There are no known drug nutrient interactions with this medication. And then smithicone, which is an anti-flatulent, can cause belching. And just the suggestion here is to avoid carbonation and gas-forming foods. And I think I missed one up top there. That's Remeron. It's an antidepressant. However, I included it because it can act as an appetite stimulant. So one of the side effects is increased appetite, weight gain, an increase in thirst, and also anorexia. And when taking Remeron, you are supposed to avoid St. John's wort. So still going on with the assessment here, we have the clinical and medical conditions and intake that I'll go over briefly. As I mentioned before, there are a variety of pre-existing GI complications that MTL presented with. This was the constipation, the peptic ulcers, the pancreatic cysts, the esophagitis, the GERD, fatty liver, and the ascites. Her nutritional status prior to admission, as I stated, was optimal, and she reported an adequate intake, eating 3 meals a day plus snacks. However, we were unable to calculate the actual percentage of calories and protein that MTL was consuming. She had a difficulty providing a detailed intake history due to her prolonged hospital stay. And by the time that I had jumped on to do my case study, she had been hospitalized for over a month. And so really her intake prior to admission was kind of not on the forefront of her mind. So I did my best to, take her word and see what she had to say about it. Now, when she was in the hospital, we did see that she had a very suboptimal intake for a majority of the time that I was going through her medical record, things of that nature. And so we ultimately had to work really hard to ensure that we were getting her adequate nutrition through her tube feedings. As I mentioned, there's just was such a large component of this that was psychological. The patient had such a severe fear of consuming food, and ultimately she did not want to experience adverse side effects. So she didn't want to have, abdominal discomfort, no gas, bloating, any diarrhea, nausea, things of that nature. So because she was so hesitant to actually eat, we really had to rely on that tube feed for a consistent and persistent amount of time. She did not see a reason to consume foods orally, which was also a difficulty because she understood that the tube feed was providing her with her needed nutrition. So when she knew that, it was kind of like, well, if I have the tube feed, I don't really need to eat. And so it took a lot of counseling and a lot of motivational interviewing tactics and things like that to really get MTL to agree to certain interventions. And this included things like slowly eating foods that she felt were familiar and that were comforting to her, and also a mixture of incorporating those oral nutritional supplements, because ultimately we really wanted to discontinue the use of tube feeds. She did know that if she continued to rely on the tube feeds, that since the nasogastric tube that she had in place is not long term, that there was kind of the discussion going on about a peg tube, and she did not want a peg tube. She was very adamant about not wanting a peg tube, and so because of this, we had to really work with her a lot on consuming her foods orally. Her calorie calculations initially was 25 to 30 calories per kilogram. That came out to about 1560 to 1870 calories a day. That was with her initial body weight, the 137 pounds. They did adjust when she moved to LTAC, was increased to 30 to 35 calories per kilogram. That came out to 1440 or 1680 calories a day, and that was used on our best estimated dry weight, which was the 48 kilograms or the 106 pounds. Again, her initial protein calculations were 1.2 to 1.5 grams of protein per kilogram. This was about 75 to 93 grams of protein a day, and her LTAC was 1.5 to 2 grams of protein, which was 72 to 96 grams of protein a day. So not a huge difference as far as estimated energy requirements for her hospitalization. We did go through 3 different diagnoses for MTL during her stay. So the first 2 were previous diagnoses at Sparrow Main Hospital. Ultimately, when I saw her, the diagnosis became altered GI function related to slow GI function, the HSV esophagitis, as evidenced by difficulty upon swallowing with coinciding poor PO intake, the need for nutrition support to meet needs, and the previous ileus at Sparrow Main Hospital. So for the intervention, really the plan of care here was to address both the short-term and the long-term goals that we have for the patient. So ultimately in the short term, we really just wanted to address those symptoms, wanted to provide adequate nutrition for the patient, and also just provide support, really give as much information as we could about the symptoms and just how to adequately feed herself in the situation that she was in. And then the more long-term goals that we had was to provide education on how to minimize flare-ups, and so that meant increasing periods of remission, and so this is incorporating that lifestyle change that I mentioned before, and also just how to continue with adequate nutrition without the need for nutrition support in the long term. So as I mentioned, we relied heavily on enteral and parenteral nutrition. As I said, the prescribed formula, the Peptamen 1.5, met 100% of the nutritional needs for the patient. On average, she was receiving about 87% of the tube feed according to the EMR, and ultimately it was decreased to nocturnal feeds, which met 50% of her needs via tube feed, and it was hopeful that she would meet 50% from oral intake. The parenteral nutrition, she was initially underfed with the PPN, and then once we advanced her or got central access and she received the TPN, she was provided 100% of her nutritional needs. However, the TPN did not last too long because she had elevated LFTs and also high triglyceride levels. So these are just another part of the intervention. As I mentioned, we had to do extensive weeks of calorie counts. This first table here ultimately showed that her intake was 45 to 52% of her calorie needs, and she met 33 to 44% of her protein needs that first week that we initiated. And then this is the second calorie count. She met 42 to 49% of her calorie needs, and then 34 to 45% of her protein needs. And the last table that I have here is another week of calorie counts, and she was meeting 37 to 43% of the calorie needs and the 34 to 45 of the protein needs. And so ultimately, these were pretty much proving to us what we already knew, that her intake was suboptimal, but also it was justification for continuing the tube feed, and also enabled us to get an idea of how likely it was that she was to meet 100% of her needs orally versus needing to rely on that tube feed. So as I mentioned, the counseling sessions, it just required real persistent guidance and motivation on our end. There was that psychological and hesitation coming from the patient, and so ultimately it just really needed persistent reassurance. We needed to provide a lot of information just on high calorie, high protein food ideas for the patient. We really wanted to ultimately discontinue the use of the tube feed, and in order to do that, MTL really needed to have a good understanding of what high calorie and high protein foods she should be consuming in order to meet her needs adequately. A lot of our counseling sessions continued to focus on the need for the tube feed. We had a lot of discussions about, the desire to get off the tube feed and ways to do that. And it a lot of times was back and forth, but eventually, after a lot of meeting and explanation, and just a lot of informing the patient when she wasn't meeting her needs, this all kind of helped to ultimately help with us discontinuing the tube feed, which we were able to do on the last day that I saw her, so on my third follow-up visit. So again, we had to just educate on how to get adequate intake and also how to get over some of those psychological factors that were really proving to be issues for the patient. So the coordination of care in the intervention, obviously we work with a lot of different professions, a lot of different health professionals, and so that includes things like the physicians, the registered nurses, the speech language pathologists, the physical and occupational therapists, the case manager, and then again the dietitians who are on the team as well. One thing that was important for MTL was just at least getting her up out of bed and trying to get her to walk to promote some of that gut motility and mobility. And so we did try to schedule her more physical and occupational therapy visits in order to just get her walking, get her up. And so that was one thing that was really important. And ultimately, on the last day that I saw her, we were working with the case manager for discharge paperwork. So I was really hopeful that on that last day she was about to go home. And unfortunately, that did not happen. But at that time, it was very encouraging to see that we had made so much progress and we had ultimately been able to work all together as a team to provide MTL with the level of care that she really needed in order to make progress. So as I mentioned several times, um, this slide is just really going over just some of the progress that we saw. So initially the intake was very poor on the initial visit. On the follow-up visit, again, very poor. The next visit, we slowly start to see improvements in the intake. And then on the last time I saw her, her intake was improved enough that we could just continue the tube feed. So it was a slow, steady race to the finish, but eventually we got there. The next thing that we were kind of looking at was her progress in the clinical picture. At the initial visit, we were having lots of symptoms, lots of gas, lots of bloating, lots of nausea, lots of abdominal distension. And throughout the follow-ups, symptoms started to dissipate. We started to see them becoming less and less. And then on the last day that I saw her, the only symptom she reported to me was a fever. So no actual GI issues that we saw there. So that was very encouraging. And behaviorally, again, this was very integral to this case study. We saw that on the initial couple visits, she was just very non-compliant and very hesitant. By the third follow-up that I had after working with her, she was still very hesitant, very scared, but she was starting to make small improvements. She was willing to try things. And by the last time I saw her, she was very open to working with us and trying things and doing her best, really the best that she could to help herself and adequately feed herself in order to get off that tube feed. So the standard of care. Ultimately, through her time at Sparrow and when I was working on the case, the standards that were needed were met. As I went over in the medical nutrition therapy section, the first thing to really address is nutrition support. That's what we did. We initiated nutrition support to help meet her nutritional needs, and so that was met. Adjusting energy requirements, so those increased needs that she had, we did adjust in the setting of her Crohn's flare-up, so that standard was met. And then ultimately just working on a specific individualized diet to find things that worked for her. That standard was also met. And then we did help with the deficiencies that she was seeing. So the potassium, she did have a B12 deficiency, but also both of those she was receiving supplementation. And so ultimately, the three main standards that need to be addressed were addressed, and they were addressed very effectively and sufficiently, and I think that the level of care that MTL received was just phenomenal. So the impact of medical nutrition therapy on cost. So I spent quite a while researching this. I couldn't find any current studies that really talked about the impact of medical nutrition therapy and cost effectiveness for the hospital. The Academy of Nutrition and Dietetics actually has a study that is set to begin on this topic, and so I will be interested to see and go look at that when it's initiated and completed and see what they find. My thoughts on it is pretty simple. I feel that if you adhere to an appropriate diet, if you make those lifestyle changes, if you follow the ultimate recommendations, you're more likely to stay in your remission phase with much less Crohn's flare-ups, which ultimately means less hospital visits and no need for that nutrition support initiation. And so I do think that if you do follow the medical nutrition therapy for Crohn's disease and IBD, you are more likely to find that it is more cost effective. So really, in summary, based on this whole case study, I think the biggest takeaway here is that IBD and Crohn's disease is so highly individualized. There is no right or wrong way to go about it. There is no correct counseling strategy that needs to be applied. It needs to be so patient-centered, and your interventions need to be tailored exactly to the patient that you're seeing. Otherwise, you're not going to see successes. So I think ultimately that is the biggest takeaway that I've seen from doing this case study. I do think that all nutritional components need to be addressed. So looking at any other pre-existing conditions, looking at the labs, looking at the medications, seeing how it's all connected. I do think that's also very important in the successful MNT of Crohn's disease. And I do think just ultimately you really need to be flexible and need to adapt to the level of care that's needed for each patient. So whether that's a tube feed, whether that's not a tube feed, or adjusting the diet, or just providing the patient with information, I just think it really comes down to making sure that the intervention and the level of care that you give is specific to the needs of that patient. I want to thank you for listening to my case study presentation. I hope that throughout this presentation you've been able to take something away from it. If you do have any questions or comments or anything you'd like to talk to me about, feel free to email me. That's my email listed there below. I'd be happy to talk further about this topic and answer any questions that may have come from the duration of this presentation. These are the references. When I was saying research throughout my presentation, the footnote on the bottom of the slide provides the corresponding number of the research articles and sources that I used for the information and research that was gathered for this presentation. Here is the last slide of references, and I just want to thank you again for listening to my case study, and I hope you found it helpful and informative, and ultimately I hope you have a great day. And if you do come across a patient who has IBD or Crohn's disease, that you're able to use something that you learned from this and ultimately use it for the good and the level of care needed for that patient.